case presentations today, and the topic today is surgical management of drop head syndrome. And on behalf of my colleagues, Jens Chapman, Bob Hart, and Amir Abdul-Jabbar, we put together a very nice kind of review of the topic. Dr. Chapman is going to give a talk and introduction about the clinical management diagnosis of drop head syndrome. And then in addition, we also have some excellent cases that we're going to present and review. And then hopefully at the end, we'll have some time for discussion and some thoughtful interactions between our colleagues who will be joining us on the internet. So without further ado, Jens. I think yours is.
Thanks, Rod, and thank you all for joining us. And hello to our friends in Texas. Dr. Lieberman's there, Dr. Geyer, Dr. Ziegler. I don't know where Dr. Blumenthal is, but I thank Rod for putting this together. And I extracted some slides out of a long instructional course lecture we gave a couple of years ago on dropped head syndrome, a topic near and dear to my heart. And again, I have no conflicts of interest in this regard, but it's been a big picture interest of mine for a long time because I think it's one of those unsolved problems. And here, Gary, come on in. I need to say hi. You guys need to say hi to Gary. This is Gary, and he runs our lab. And he's the classiest New York fan I know.
I hope so.
Yes. And he's just coming here to congratulate me on the Celtics win against the Nets.
Goodness.
Right?
Oh, my goodness.
Sorry. Okay. Thank you. But Gary runs our lab, and he's amazing, and the best courses, and we're having a couple of courses coming up. So this is a 1,000-foot Seattle overview, and in case you wondered, we're in this yellow box right over here, the Swedish Neuroscience Institute, of this topic. And for me, the cranium and cervical spine interrelationship has always been an amazing balancing act. We should have about 15 to 20 degrees of lordosis, and to me, it always is likened to a bowling ball on a pin. I mean, this is really just a really big problem. And especially as we are more and more keen on having our head bent forward to catch our smartphones, we put disproportionate, sorry, it's a German slide, forces onto our spine. So double the kilograms roughly, and you get into the pound sphere, about 50 plus pounds when you have your head tilted forward 60 degrees. And you can see where the weak spot is. It's the cervical thoracic junction. And in this bottom left graph, you can see a man fire up his accessory neck extensions of the trapezius. It's also known as the wing sign. So not a wingman, but a wing sign. And that's a sign that your actual physiologic short and long neck extensors do not work anymore. You basically recruit your traps with that. So this is a problem. And this trapezius wing sign is a clinical sign that we look for. The dropped head syndrome does not have a really great definition. It's basically a decompensated craniospinal alignment, and anything anywhere in this whole chain of multiple bones can go out of line. And it's a fluid transition into the global spinal decompensation. And again, basically, one of the key first things we have to understand is that when we see a patient who comes with a derangement of their spine like this, their GPS, their internal compass is out. Something has really gone sour. And to just reduce that to a structural alignment measurement really does not do this justice. Now here, please be warned, comes a full slide. So when we look at cervical kyphosis, we always want to look at focal and systemic issues. And again, these are very different habitual and muscular things, compensatory postures, iatrogenic things, and we'll have a couple of cases with iatrogenic issues and post-traumatic issues, infection, neoplasia, post-radiation myopathy, not myelopathy, but myopathy, dysplasia, neuromuscular issues, which is a really big deal. Think about myasthenia gravis also, slightly related, non-related. Anterior soft tissue contractures, for instance, after oncologic surgeries or radiation, inflammatory conditions, collagen disorders, etc. This is a whole laundry list, and I apologize for having made it like that. Jared, we'll call you back later, okay, so you can sit down. Thanks. And so effects of kyphotic alignment are a big deal. Again, this is ISSG material, and these numbers are all Very, very relevant for us. But the key thing is that the cervical thoracic junction and the cranium has been affected by that. And until recently with Chris Ames's studies, until we understood the T1 angle more, this was really not well understood. And sorry about this. But the key thing is that I'm just showing this kyphosis case in the thoracic spine. Look at the cervical spine and how this has changed. And again, a physiologic lordosis really requires that the thoracic spine, the foundation of the spine, is somewhat correct. These are older slides, but again, especially in elderly patients who can't compensate that well with their muscles and have some form of an acquired or de facto myopathy or just physiologic loss of muscle tone, this becomes a bigger and bigger issue. And again, then we have these long extensors, this is Galen's famous picture, and then the accessory extensors like the trapezius muscles fire. So there are a couple of consequences like pain, chronic myofascial symptoms, the famous C7T1 area junctional pain. There's a propagation of cervical disc degeneration, instability, postural compensation, neural impingement, and deformities. So this propagation effect is clearly present. Once you start having collapse at one or two levels, in the cervical spine especially, this is something that just really fires up. And maybe Bob, can you take one of my microphones? Oh, no, this is a bad time. Rod, do you want to talk about that? So this propagation effect, or why is this, or is this true that this is more prevalent in the cervical spine, the thoracolumbar spine?
I'm not positive that it is, but I would say it's certainly an issue in both, right? And kyphosis begets kyphosis. Once you start to drop forward, the loading of what's left just drives it further in that direction. So it certainly is an issue in cervical spine. And I think you're probably right. I think, we don't end up with kyphosis in the lumbar spine. We end up with hypolordosis. In the cervical spine, we end up with true kyphosis. And I think it's because we start with less to begin, maybe less lordosis.
Okay, great point. Stay on the microphone because for me, it's always been fascinating that when you have this kind of a collapse of discs, you have also something called segmental instability where the levels above start translating. Like for instance, when we have C5, 6 and C6, 7 collapse rod, then C4, 5 kind of seems to anterolaces or C3, 4 above that. Is that a correct observation or is that just made up?
No, I think that's correct.
So postural compensation. So maybe I'll ping this onto. So this is again a classic end result. I think this is actually the same patient who basically over about 10 years in my time at UW basically went from a simple anterolacesis to a decompensation where there was just this forward slippage and kyphotic collapse. The next phenomenon is postural compensation. And again, this is something I just alluded to in that previous Sherman's case. This is a classic problem because patients will develop the so-called simian posture. So it's hip flexion contracture. And we also have a little nickname here. It's called Bazem sign. So when we have patients with subaxial kyphosis, they then compensate with so-called Bazem sign where the C1 arch pinches onto C2. And you have, again, this anterolacesis effect that we just talked about seen here in this patient. And basically the concept is subaxial kyphosis leads to compensatory upper cervical lordosis and posterior element impingement, or in this case, even like a cord impingement front and back. And this is a real problem. This is Bazem Ishak. And he just recently gave a great STED talk on upper cervical spine mechanics. He's the chief of spine at Heidelberg in Germany. Neural impingement, of course, there are multiple factors in this. And one factor is how much spinal canal space has been there in the beginning. How does the patient respond in terms of disc herniations versus osteophyte effect? But this cord draping effect is particularly deleterious in terms of having a problem with the anterior cord compression. And then this is, again, one and the same patient. Over time, you get this progressive deformity with a truly devastating cord impingement and cord draping effect. And the consequences, again, are further in terms of the disease part. So the final thing is deformity disease in the cervical spine. And this is very uniquely different probably from the thoracolumbar spine, where you have pain, progressive myelopathy, syrinx formation and scar formation, loss of mobility and motion, limited visual horizon where the patients then start turning their head sidewards. We'll see that in a second. They fall more because the center of gravity is in front. They develop swallowing problems and aspiration problems. They're usually elderly. And again, their normal interplay of their larynx separating the airway from the intestinal tract goes kaput. They're far more at risk of anorexia also as a secondary effects. So these are really these side effects of a deformity disease in the subaxial spine, which leads me towards my final point. That is, as we look at patients, we obviously are interested in angles. We look at all sorts of degrees and compression effects and this and that. But for me, the word Gestalt is a great German origin word. It identifies the shape of a patient in more than just the visual angles. It's the overall effect of a patient. And this picture to me embodies so many of these patients have a dropped head syndrome or a beginning dropped head syndrome, as you'll see in these cases. These patients are frequently really very complex patients with multiple problems. And it's for us to detect, to sleuth out what's really going on. And again, obviously non-operative things, we cannot talk about that in too much detail right now, but we don't have any great things, but we should all really, in our armamentarium, direct traffic and identify meaningful ways to try to compensate actively and passively through traction, for instance, the worst of a beginning cervicothoracic kyphosis. This slide is not really readable, but basically there's the usual armamentarium for this experienced audience. I'm not going to read through that. But one of the key things I want to point out is swallowing studies and bone density should be considered. And I think nutritional panels, simple albumin, pre-albumin is probably all we need. One of the key things I find in physical exams is to lay the patient down flat on a bench so that they can breathe. You can see how they can breathe, and then see whether they can get their occiput onto the flat table or not whilst you hold their occiput. They have actually a slide in there, but I didn't find it right now. So this is something I find very important. It's a recumbent test. You can also see whether they have hip flexion contraction, address those. Examinations over time are important. This is a patient from 95 that I followed until 2000. Over 5 years, this patient developed a stepladder spine. And what is then very common is that these patients hold their head forwards to kind of indirectly decompress their cord. So they don't want to walk straight because they're pinching their cord and their roots. And traction can be a very helpful thing to try to understand how unstable the spine is. And simple 10 or 20 pounds in a chin strap traction setup can help. So degenerative kyphosis, these are just 3 case examples without the surgery. That's, again, a classic disease process plus minus an inflammatory disease. And we want to obviously have a neurologic correlation with this. Post-laminectomy kyphosis is a classic, nowadays almost no-no, but we still see it, with an incidence of about 20 to almost 50%. And in kids, it's way higher. And again, this is a classic severe case of post-laminectomy kyphosis. And then we want to also study the CTs to assess facet ankylosis, because this changes the whole surgical strategy. And finally, we don't want to have this. And again, maybe we'll see a case like that from one of our fellows later. And that's the open internal fixation concept, the OIF, where basically somebody fixes a neck into kyphosis. Rod, is this something that you still see a lot?
Yes.
And why is that? Is it just positioning laziness where you put the head forwards and you just kind of not want to struggle with the occiput as you put your hardware in, or what's going on there?
I mean, I think honestly, I think it's a little bit of everything. You know, I think these are very challenging cases. They often involve doing multiple surgeries, anterior, posterior, and then going back. So, I mean, I think it's a challenging problem, and these cases are often, you know, complex medically as well.
Now, you do a lot of multi-level posterior surgeries. How do you position a head? What do you use for head positioning to avoid an iatrogenic positional kyphosis?
I mean, I'm a big fan of using as little as, you know, I don't like anything that's fixed. So I use chin strap, Gardner-Wells tongs. I think, again, with, you know, like that case you showed, I think I would have not gone posteriorly first, probably gone anteriorly, maybe do corpectomy and then some discectomies, and then try to get some reasonable amount of lordosis. Then potentially have to go back, then go anterior potentially, and then try to get some reasonable cervical thoracic alignment.
And Bob, that's a great answer. So GW tongs, and I must confess, I learned from Rod. I used to use Mayfield head tongs and intraoperatively jack the head up, and I sometimes still do that. But for the most part, I've been extremely happy with GW tongs. So I learned from you there. Bob, shortness of fixation, was this just a conceptual misunderstanding of the surgeon? Should the surgeon have gone to C2? What went on there without you having the benefit of previous images here?
Well, it's hard to know, but I do think it to me suggests, sort of technical understanding without really an understanding of the pathology and overall surgical planning. I mean, I think it would have been a nicer result. I think, as Rod said, had gone from the front first. Not positive that couldn't have been done only from the back, but I think it probably would have been really, a bigger resection from the back, and really, I think, safer for the patient to do it in the front and then really get correction in the back. So it's a lack of understanding. And also, I was talking in the OR the other day. I think the first step in all of these things is really believing that it's important. And I think if you come in as a surgeon and you don't really think it's critical that you focus on alignment and get lordosis, you're obviously not going to get it. The first step is believing it's important. And then from there's the challenges of figuring out how to address it and then carrying it out.
So great points there. And then we'll see that and discuss it in some cases. And then another point is posterior soft tissue. So this left slide, I just put in there to show how high tension the cervicothoracic junction is. So having a special fascial closure, we've changed the way how we raise kind of a trapezius flap, and we close it with tagged OPDS and multiple loop fascias to not have this fascial dehiscence. And here you see a classic iatrogenic trapezius sign with midline dehiscence. So if you don't have a very good extra strong fascial closure in these nutritionally usually depleted patients, that's a problem. So this is where I'm going to end without showing the images. At this point in time, at least, this is a decompensated classic dropped head syndrome. The patient has kyphosis plus torticollis. She cannot actively raise her head anymore. She's given us permission to show this, by the way. And this is also known as a cock-robin deformity, where there's significant rotation, lateral tilt, because the patient's trying to somehow look up, and cervicothoracic kyphosis. And this is her outcome after surgery. And she was actually quite happy, and she had normal swallowing. So complex multifactorial problem, a true challenge for us to not just unidimensionally think of it in terms of bony alignment, but think not just also soft tissues, but also supratentorially and connective tissue-wise and nutritionally, and understanding the patient. Let's go for the next thing. And Rod, who do you have next?
I was gonna present a case I actually did. And I think it's a very good case because it's fairly complicated, and this patient had multiple surgeries, and you can see the evolution of her kyphosis as it progresses with each surgery. So you have Fravert.
Hey there, everyone. Good evening. Jeb Fravert, one of the neurosurgery spine fellows here at Swedish. Have a quick case to discuss here. Our patient is a 33-year-old male who presents to clinic with progressive neck pain. Patient is unique in that he has chronic OCD and cracks his neck compulsively, so much so that he's been encouraged to wear a C-collar pretty much at all times. He does have a history of prior neck interventions. He's followed by PM&R for regular injections for his neck pain. And he also complains of bilateral hand numbness for approximately 3 years. On exam, he's full strength throughout. He has heightened deep tendon reflexes pretty much everywhere in his extremities. He doesn't have a Hoffman sign, Babinski, or clonus. And his sensation is intact except for a slight reduction bilaterally in the distal upper extremity, which doesn't appear to be dermatomal. This is his imaging, and there's a lot to appreciate here, the evidence of the prior intervention. There's both a posterior construct and an anterior construct, both of which appear to be failing. The anterior construct is pulling out, at the top, and the posterior construct as well has broken screws and doesn't seem to be in its likely original position. There's a substantial amount of deformity in the upper C-spine. I'll show some images later which demonstrate that a little bit better. This is his MRI demonstrating signal change around C2, 3, and maybe 4. And you can appreciate again the beginning of deformity in the upper C-spine. Now, looking at his historical imaging, this is the original presentation for neck pain before any interventions. And you can see the beginning of that stair-step deformity that Dr. Chapman was mentioning earlier. This is his imaging after the initial intervention, which was a very limited posterior construct. And all we have is a scout film. There's no formal imaging because it looks like almost as soon as the hardware was placed, the C2 screws fractured. Almost certainly because of this gentleman's issue where he's cracking his neck compulsively. This is the imaging after the second intervention. At this point, that anterior construct looks to be better positioned. But again, the surgeon chose to do kind of a more limited fusion, which in this case with this particular pathology may not have been the most appropriate decision. So in terms of next steps, this patient is in our clinic, and we have some decisions to make. One option is to continue conservative management, which is not entirely unreasonable. He doesn't have really a formal deficit other than his neck pain and maybe a little bit of sensory loss. We could certainly consider operative intervention, and then the question is, further minimal intervention, kind of sparing the larger procedures versus something again more comprehensive. And then finally, especially in this case, again with his unique pathology, we also have to consider how to achieve the best possible post-operative outcome, and I'll address that right now. What we chose to do was, the comprehensive.
Stop you right there for a second. So we have Dr. Lieberman. Izzy, can you unmute yourself and go back a little bit more?
Go back to the one where he failed the ACDF. Yeah.
So this patient now has an unstable non-union with radiolucencies, progressive collapse, C2 through C4. The road there is interesting. Rod was so kind to ask me to take care of this patient. He had Botox injections for his neck cracking, which I've never heard of before. So for me, this is possibly an unusual side effect of iatrogenic muscle spasm relaxing injections into his extensor muscles. Izzy, have you ever heard of that? Or is that something that you've seen in Texas with its rich North Texas pain management clinic environment?
I must admit, I am not a card-carrying neck cracker society member, so I have not seen this at all. And I'm not sure that the neck cracking broke those screws. I suspect that would be pretty hard to self-induce. I think we're dealing with biomechanics and cyclic loading over time. And, I doubt the neck cracking was happening at that level. It was probably happening at the levels below. But I've not ever seen this, and it's a bizarre story. So,
and it's even more bizarre because this patient was then treated with a neck collar for I think about a year.
Yeah, quite a while.
So when he actually came to us and Rod asked me to see him, which is very nice, he had swallowing difficulty. So this plate is kicked off quite a lot in the front. So you can see, can you use the cursor on your laptop to show the air shadow relative to the anterior part of the plate?
Well, actually, right.
Yeah. So basically, this is impinging his larynx now. And the second thing is that when he is asked to hold his head straight, he actually tips his head forward. So he's been so completely kind of immobilized. He has a iatrogenic myopathy also from immobility. Good. So he with strength can just keep his head straight, but nothing else. So where to go? What should we do now? Should we do an all-out front back? There's this plate that's sticking somewhere into the esophagus. It's not eroded it. There's loose hardware in the back that's around his vertebral artery, but not toward it for some reason. And there are two unstable lytic non-unions in the front.
Are you asking me again, Jens?
Heck yes. Or do you want to punt?
No, I don't punt. This is clearly a tough situation. And is this gentleman of normal mental status? Can he participate in his care, or is there some developmental issue?
No, he just has really bad OCD. Yeah. Is the main issue. Yeah, but he's normal, like doesn't smoke, doesn't do drugs or doesn't drink. He likes to game a lot. He's a big gamer.
And that didn't help.
That's his full-time job is gaming.
Yeah, he actually is a gamer. It's hilarious.
So I would approach this in multiple stages, and I would tell him this is going to take multiple stages. And the first thing that I would do is an anterior procedure to remove that plate and just assess what's going on at the inner body spaces to see what the pseudoarthrosis is like. I'd also get multiple cultures to rule out an occult infection. On that same day, I would take out the posterior hardware as well, but I would not re-instrument him as yet. Once you get all the hardware out, I'd put him in traction and see what the alignment's like, see what you can regain in that area. And then, pending what you see there and pending how he feels and what his neurologic status is like, determine what the next step is. I suspect my third step would be a posterior instrumentation, and it may be occiput down, but if we're lucky and if you can skirt some screws into C1 and maybe there's some bone on C2 with translaminar screws or sublaminar wires, you can get down and preserve the occiput C1 junction. But depending on what the alignment is, I'd go down and probably wouldn't hesitate to go beyond the cervical thoracic junction in someone who you're not going to be able to control his neck cracking.
All right.
Let him recover from that, and then probably a fourth stage, depending again on what you see. Oh, and the other thing I'd use are cervical pedicle screws in the sub C2 region to really get a strong hold on the neck so you can get a much better realignment. And then,
whilst you're talking about that, I'd like you to do an interesting case discussion one of these coming Tuesdays on cervical pedicle screws, because you're kind of one of the nation's leaders on this. So, because that's also why I asked you whether you do cervical pedicle screws on this man.
Yeah, fair enough. We'll get that scheduled at some point. But then the fourth stage, to go back to it, is probably some kind of anterior procedure to fill up gaps, because I suspect that there's going to be some big gaps there.
No kidding. All right, Yev, let's take us forward, and then we have more cases to go.
Fantastic.
Yeah.
So we did much of what was discussed, but with some variations. The patient was taken for a front back intervention, removal of the prior plating C2 through C7 ACDF, was then flipped prone. The posterior hardware was removed. C2 to T2 fusion was performed. C2 was particularly difficult. You know, one of that screw fragment there was very close to the vert and was very difficult to remove, so it was left in place. Bilateral laminar screws were placed, and then finally the patient was placed in a halo with extra pins. These are the laminar screws, and they were also accompanied by sublaminar wires. This is the post-op imaging compared to the pre-op films, and then very briefly, in residency, I never encountered more than 4 pins on a halo, but for this patient specifically, because of his pathology, his OCD, and his compulsion to move his neck, we placed him in the maximum amount of pins, which in this case I believe was 8. And there's a paper looking at this in the literature from 1997, which does show a significant increase in rigidity and potentially a benefit to healing with the placement of more pins, 15 to 20% more.
How'd the patient do?
He's 3 months post-op at this point, recovering well. His swallowing is coming back gradually. I think at this point he's near normal. So far the hardware is intact as far as we know based on the last imaging.
So we just took his halo off, all 8 screws and pins were removed, and he's back to gaming and doing well.
So Izzy had raised a great point about going to the occiput or C1. Vincent, was it a mistake that we didn't go to the occiput? Can you go back to a post-op image that you've collected? Would you have gone to the occiput or C1? You have to unmute yourself. You're still muted. Okay. Well, we'll go on.
Sorry, Jens, I didn't throw the case. I'm going to be honest. I just
Okay, we'll involve you in the next one. So we tried to preserve craniocervical motion as much as possible. And again, also C1 and with good C2 fixation where we had both translaminar screws and a pedicle screw, at least unilaterally. We felt we had very good rostral fixation. All right, so we'll go on in the interest of time. Thank you, Yev. And we have Nathan Pratt here. Rod, any thoughts about this case?
No, I mean, it was,
C1?
we did this case together and I think, boy, the C2 was extremely difficult. You saw, I mean, he had no lamina and actually the pedicle screws from before had eroded the superior wall. So it's almost impossible to get a pedicle screw in. Okay, Nathan's next.
Gotcha. So a little bit of a different case from some of the others. It's a chest deformity of Nathan Pratt, one of the fellows here at Swedish. This is a 42-year-old woman that came with an incomplete quadriparesis and spasticity with a cervical spinal deformity presenting to us after resection of a cervical intradural extramedullary tumor at C2-3 and a reoperation for an arachnoid cyst at this location in 2020 with additional cervical spinal fusion surgeries due to persistent neck pain afterward. She's been having increasing falls. She had been ambulatory. She is having worsening weakness. She's having neck and back pain as well as diffuse spasms. She's had multiple baclofen pumps attempted. Those have been unsuccessful in treating her symptoms. The surgeries are as listed. She had the laminectomy, resection of meningioma. Then she had an extension of that laminectomy up to C1 for an arachnoid cyst that formed postoperatively. She then underwent a C3 to 6A CDF and a C2 to C6 PCDF for development of kyphotic deformity and severe neck pain, and then had multiple trials of baclofen pumps and eventually removal. Otherwise, there's not much for her. Diffusely, the patient is spastic with at least 3 to 4 out of 5 strength and all muscle groups, so it's difficult to test them individually because of how rigid she becomes. She does sit with a stoop forward posture, but she doesn't have a fixed deformity. She is able to raise her head up. So going back in time to the first presentation, this was her spinal tumor, turned out to be a Simonis meningioma, resected in 2019 after resection. A very nice outcome there. Unfortunately, she developed a arachnoid cyst in that location, had worsening neurologic deficits, and was taken back for further resection of the lesion and for an extension of her laminectomy. I think you can already see she's developing kyphosis at that level. I don't think that it either wasn't recognized or just wasn't addressed at the time by the other surgeon. She was taken back to the arachnoid cyst resected with the revision of that C2 laminectomy. Now you can see all the bone removed posteriorly from C1 down to C3. With no instrumentation at all, and she's clearly beginning to tilt forward. She came back with worsening neck pain in June of 2020, so about 5 months later, she's following up saying that she's becoming more spastic, she's got neck pain. The surgeon who did the initial surgery took her for a C3 to 6 ACDF to introduce some lordosis, and then a C2 to C6 PCDF to stabilize her. Following surgery, the patient didn't really she had some moderate improvement immediately afterward, but never really regained function to where she had been. She was still fused into this sort of kyphotic alignment, which ends up being an issue that brings her to us. She has obviously the persistent pain. She progressively subluxes C2 on C3 because she's got a rigid segment above a mobile segment above a rigid segment, and has a pseudoarthrosis at the 2-3 level with the pedicle screws loosened. The baclofen pumps were attempted at that time and failed. She starts to develop progressive kyphosis, and here's where she presents to us. CTC spine shows that she developed a progressive kyphotic deformity. Now with debilitating neck pain, worsening gait dysfunction, and bilateral numbness and weakness that has progressed from her sort of baseline quadriparesis. She's now very uncomfortable with this pitched deformity. And here's her standing scoliosis x-ray. For what it's worth, she has 10 degrees of kyphosis. She has additionally has kyphosis between the occiput to C2. The CBVA is actually a little difficult to analyze in her because they inconveniently did not include her brow. But if you extrapolate, it's probably around 41 degrees. She's almost staring straight at the ground. And then her T1 slope also is more kyphotic than should be. So at this point, I guess we asked about surgical plan, treatment strategy.
Sig Bervin, UCSF, by the way, congratulations on your recent grand rounds. That was really cool to see and to participate. Thank you. Sig, caudal fixation, multi-level cervical spines, how low should we go? C7, T1, T2, or lower? What are some of the factors to consider here?
Yeah, firstly, in terms of an etiology here, I think clearly this is probably a neuromuscular type of problem. There's not been much change from C2 to C6 was the initial fixation. And you can see that T1 slope has changed. And you made a point in your initial discussion where you talked about when to recognize subaxial and pathology of subaxial spine, as well as when to recognize pathology in a subcervical spine. And that T1 slope, when we're seeing a T1 slope in general more than 20 degrees, that's what I'm thinking about looking below the cervical spine. In this instance, I think we've got a neuromuscular pathology. Another brief thing I want to bring up is you talked about a rapid progression, or what we recognize as neuromuscular is a rapid progression of an atypical deformity. And anytime we see somebody who's had an atypical deformity, typically a patient with a significant sagittal plane abnormality or a progressive coronal plane abnormality that's rapidly progressive, I think we under-recognize neuromuscular pathologies. So getting more focused now on your question, how far down do we go? And to me, this is, I'd like to see that CT scan again, but there's probably a cervical thoracic junctional problem. It's that T1 tilt that I want to correct. And lying down is not quite as sharp of a kyphosis as it is with her standing up. But in general, I may think about doing an osteotomy, typically at the apex of the kyphosis, which to me looks like it's somewhere around T3. And T3 is a pretty nice place. Osteotomy is relatively safe from a neural perspective. And that seems to be close to the apex of deformity. If I'm doing a 3-column osteotomy at T3, I'm going to try and get down to a vertebra that's touched by the posterior sacral line. And this may seem distal or may seem controversial, but I'm probably going to go down L1 here. So if you were to draw a vertical line from the posterior margin of sacrum, I don't want to stop at a segment that's kyphotic. So you're trying to get to the first lordotic segment. That was a rule that we use oftentimes in Sherman's kyphosis, or to the vertebra that's touched by the posterior sacral line. And again, looking at this right now from where I can see it, that's probably going to be L1.
Great point. Okay,
Yeah.
Nathan, why don't you take it ahead?
Very nice.
High predictive value there, Sig.
Yes. Yeah. You foresaw what's about to happen. So the patient underwent a C1 to T8 posterior cervical thoracic decompression spinal fusion. She had posterior column osteotomies, not a full 3-column osteotomy at C7 to T4. The surgery went very well. Actually, the patient felt great improvement in her neck pain, slowly improving her neurologic symptoms. Though obviously those are sort of long-term deficits, but overall she was very happy initially after the operation. The alignment was improved. I think we discussed that T1 slope is still not back to normal, but improved from where it was, and that may be an overestimate a little bit. And well, this is actually after she started to have failure anyways. There was no initial post-op. So she's already starting to have some issues at this point. Unfortunately,
She also had another baclofen pump place that got infected.
that's right. I forgot.
So-
I left that out. Yep. Yeah, another attempt at treating her spasticity, infected, removed the pump, which she comes back to clinic with progressive kyphosis, severe mid-thoracic pain, now debilitating lower extremity pain, weakness, dysfunction in her lower extremities. She's found to have distal junctional kyphosis at that T8 segment, despite a cement augmentation. It's not apparent from the imaging, although you can see the size of the screws there. She has very small pedicles and very weak bone. And so the patient was then taken back to the operating room. The surgical plan at that time. Oh, do we want to discuss that, or do you want to just show what we did?
So if Vincent, in retrospect, SIG predicted what was happening here. Would you have gone to L1 with cement augmentation? Do you have any DJK prevention tips, especially when you have a rigid cervical thoracic junction? Let's switch to Izzy. Izzy, we lost Vincent right now.
I'm still here. I must admit, I would have not gone down that far on the initial. And I have, much like this case, been struggling with where to start and stop, and have ended up with this same situation. So I would have not. I would have limited my construct, maybe even 1 or 2 levels shorter than T8. I may not have even gone down to T8. But that's with the retrospectoscope, of course.
So again, if we assume an apex of T6, I don't know how it was in this patient. Do you want to go below that apex? Is that your principle, or are you comfortable to correct the patient and stay above the apex, like a T4 or T5?
I tend to look more at the overall balance and try to get an impression of how flexible that thoracic spine and lumbar spine are going to be. This was a young individual. I would have assumed, am I correct? Did I hear you say she was like only 30? Or he only 30?
42,
yeah.
She was 39 when she initially presented way
Right.
back. Well,
So
way back.
I would have assumed that this spine is pretty flexible, her hips are pretty flexible. She's going to be able to accommodate if you don't have the sagittal alignment just perfect. So I would have not gone down that far and tried to look at the full length films and figure out where to stop, and probably regret it.
I think a couple of things that influence the decision here is, first of all, you mentioned poor bone, but she's neuromuscular, right? She's quadriplegic. She probably doesn't have intact extensor muscle function. So there are circumstances where I might be willing to stop at T4, even T6, very rarely T8, which is the apex of the kyphosis. But those circumstances where somebody's got good extensor muscle function, normal bone quality, and I think that there were a number of factors that would lead me to feel even more strongly about getting down to a vertebra that's touched by the posterior sacral line, and to a vertebra that's not so far behind the center axis rotation, and specifically her neuromuscular status as well as her osteoporosis, even though she's young.
Great. Okay, so lead us to a conclusion there.
All right. So the patient was then taken back to the operating room with the plan to extend her down to T11. When we exposed the hardware, we immediately saw purulent fluid around the screws and coming from the vertebral body at that level, at the T8 and at T7 level. The instrumentation was still placed because of the nature of the fracture and the patient's symptomatic progression. She did have some improved alignment. Unfortunately, I don't have an actual X-ray. I just have the scout from the CT scan. Clinically, she unfortunately came back to the OR again for a wound washout and placement of antibiotic spacers. Obviously, the hardware is left in place, but she's going to have to come back for additional surgery at some point after about 6 to 8 weeks of antibiotic therapy.
Did you get upright X-rays prior to discharge?
This is the last upright that we have, and it didn't go all the way down. She does not have a full
So you ended at T11 now.
Yeah, the construct ends at T11. Yeah, unfortunately, she doesn't have a full-length standing scola yet.
Okay.
So,
Yeah,
what was the bacteria that grew out? That's going to be very interesting.
Oh, MSS.
She had multi-organism in the beginning, but I think it was just MSSA.
I think it was just MSS.
Yeah. So.
Yeah. Yes, Nick, we had heavily debated that between T11 and L1. Again, briefly share with us why you would go to L1, what line you're looking at relative to T11.
Yes, this was described in a setting of Sherman's kyphosis by Larry Lanke. I think a good general rule to go with is get to a lordotic vertebra. And that's something that John Hall talked about at Tom Lowe with regard to managing Sherman's kyphosis. And I try and apply those principles to these cervical thoracic cases as well. So the first lordotic vertebra is what I'd be looking at. And then with regard to the position of that distal instrumented vertebra compared to the posterior sacral line, if we draw a line from the posterior margin of sacrum, make sure that that vertebra is touched by that posterior sacral line. And again, like you wrote about that as being a predictive of a reduced incidence of distal junctional problems, again, primarily in Sherman's patients.
All right. Okay. Next case. Thank you for the comments and great education. And
We have one more after Zach.
okay, then Zach is coming here.
Zach,
Zach
can you give
Tataran?
5 minutes.
I'll do it quick.
We just came out of the operating. I'm sorry for that. So this is Zach Tataran. And are you downloaded already?
Yeah, I'm okay. Here we go. There we go. I'll make this one quick. This is a pleasant 77-year-old male. He has progressive neck pain and difficulty feeding. Intact on neurologic exams, save for diffuse weakness throughout, 4 out of 5 throughout. In addition, he's grossly myelopathic, but has actually drop reflexes. This is a scan from 2013, just an AP or lateral plane film, and then a CT he got. I'm not sure why he got these at the time. Then progressing to a MRI from 2015 when he had worsening neck pain. This is when he presented to us in 2019. So 2013, 2015, 2019. You can see he's dropped forward and a bit off to the right. We got flexion extension imaging on him. He had some subtle motion, but he clearly tips forward. Pre-op CT myelogram, numerous areas of quite severe stenosis.
Of note, we did this with a cervical chin strap traction. So this is actually a traction film with a 10-pound setup.
Wow. Pre-op MRI, 2 levels of majority of the tightness, C2-3, C4-5. So these are his X-rays, CT myelo, MRI.
So let's just drive it forward. So what do we do? And then we'll discuss what's happening.
So these are the pre-op scans. He's taken in the OR for ACDFs performed from C2 to T1. Osteotomies for realignment from C4 to C7. Posterior instrumented fusion C2 to T3, C2 to T1, Lammy's. He had a peg tube placed preoperatively. I neglected to mention he'd had some feeding difficulties and some aspiration problems as one of his chief complaints when he presented. So a peg tube was placed preoperatively. Post-op CT scan shows much better alignment. That's a midline and parasagittal showing the screws in the rod. There's 2 rods, one on each side, obviously. And these are the post-op plane films. Patient did very well post-operatively, went home in stable condition, was reportedly stronger than they were on admission. These are 2 years post-op plane films. And so in comparing pre-op, post-op now, these current films were taken just a week ago. He was seen last week in clinic. He has no complaints. He's very happy, even though he appears to be pitching forward a little bit more once again, kind of showing the trend of.
Did you get the scoliosis film?
This is the most recent ones that they have.
So I want to ask you, Sig Bervin, and then Izzy briefly to comment, then Bob Hart. So should I have gone lower, or is this just expected? I mean, there's no single fracture, but his general gestalt, again, I come back to that word I introduced before, it seems that he's wanting to fall forward. So what are your thoughts?
I'll start then, Jens. I think you did a terrific job of getting realignment in a subaxial spine. So C2 to C7 anterior reconstruction. You got really nice lordosis. And if we were to use a metric of a C2 to C7 lordosis, then that's really nicely reestablished. Clearly, the problem here is T1, right? And again, a T1 tilt has got to be at least 60 degrees there, and that leads us directly to think about the subcervical spine. And it looks like he's got a thoracic kyphosis that probably measures close to 90 degrees now. And so this is a subcervical spine problem. And if he's asymptomatic, then terrific. Having said that, we know from Chris Ames's work that in general, when the centroid of C2 is more than 4 centimeters in front of the back of C7, then that's associated with increased disability. But if he's doing well, then I wouldn't do much about it. I might not have predicted this failing given the preoperative standing film. The fact that he's able to achieve that hypokyphotic thoracic alignment preoperatively, which it looks like on that short film, but it looks like hypokyphosis with thoracic spine, that's a good proxy for extensor muscle strength. And I might not have predicted this falling into that kind of kyphosis.
Izzy, I took your advice. I stopped at T2. We left all the junction ligaments nicely in place. There's no actual fracture at the cervical thoracic junction or between T1, T2, T3, T4, et cetera. It's just a general sag. How do you want to handle this? Could I have prevented this? Did I go too long? Or should I have gone to the Zig-Bervin L1 vertebra maybe?
The description is that he's currently doing well. He's asymptomatic. Symptom-specific surgery. Someone earlier on talked about life being a kyphosing event. He's going to continue to kyphose. If he's tolerating it, you did the right thing. If you went further the first time around and got an infection or a neurologic injury, you wouldn't be happy. So I wouldn't second guess this one at all. Well done.
Thank you. His center of gravity, by the way, is well in front now. So he is using a tall walker, which I'm very keen on. Bob, critique me. So Izzy is on my side. Sig was not so on my side.
I perceived they were both, kind of in your court there, but which is where I want to position myself as well. I think, as Sig said, this is not a cervical deformity at this point. This is thoracic deformity, and I think it has progressed a bit between the middle film and the film on the right. I think all of us are in agreement that if it's not bothering him much, I think no one among us would propose significant surgery. I mean, I think if you do try to deal with this now, you're probably looking at going almost, there's an argument to be made to go to the pelvis because this guy is going to fail somewhere else if you stop really anywhere in thoracic or lumbar spine. My guess would be, and I would underline what Izzy said, this is not, or maybe it was you, Jens, this is not a distal junctional failure, it's a distal junctional kyphosis. And I think we're just getting our arms around distal junctional problems, but they certainly are very prevalent in these long cervical thoracic fusions. And I don't think I have a lot more to add. One thing I will say, I think both of these cases, the last one, this one, and the one just before, to me they are neurologic problems. And I think they're a central cord phenomenon from C1, C2 level. And I first saw this in a patient with an odontoid fracture and a cord injury at that level. And when I went back and reviewed the anatomy, the central fibers at C2 are all the paraspinal muscles, and those exit before the fibers to the upper extremity. So a central cord syndrome at C2 looks like this, paraspinal paralysis.
Really good point. All right, one more case, Jerry. And then we have Jared Cook for a brief summary. This is Jerry Robinson sticking all of us just came out of the OR. I apologize. None of us wear suit and ties or smoke a cigar like Jack Ziegler. Adapter problems?
No, here we go.
All right. My name is Jerry Robinson. I'm a ortho spine fellow here at Seattle Science. This is a 67-year-old female with neck and trap pain, pitch forward neck, chin on chest posture that's been worsening over the past year. Currently not having eating issues, swallowing well, and using a front wheel walk for ambulation. She has a history of psoriasis, RA on methotrexate, chronic steroids, and aspirin. Had a history of Harrington rods in the 80s and then an L2 to S1 fusion in the past. This patient is essentially neurologically intact with some upper extremity hyperreflexia. And then if you notice here, posturally, the patient is unable to get the back of their head to the table about 7 finger breadths. So it's a rigid deformity. Here you can see T4 to L2 rods, L2 to S1 fusion. Here are your spinopelvic parameters. Does have flat back, as well as a 6 centimeter SVA, and then the T1 slope essentially 90 degrees. I'll zoom in on that here in a second. Here you can see essentially 80 degrees from C7 to T4, or the most farthest down able to be measured on this CT scan, about 120 degrees. Here you can see on their CT scan, it's essentially pointing at the ground, their T1 slope, but relatively somewhat preserved lordosis around 30 degrees. Here you can see a standing X-ray pitch forward, pointing straight at the ground. And here's an MRI for completeness sake that you can see the compression. So in summary, severe rigid cervicothoracic deformity with chin on chest and their associated parameters. So plan.
Go for it.
So number one, PEG tube 1 month prior to surgery, ACDF in the subaxial spine, and then a posterior based fusion, removal of the hook system. There was complete fusion on the CT scans, expandable cages, IDOs at T2-3, and then Lammys. So here you can see the correction with the cages placed anteriorly with the expandable cages. Here you can see the relative alignment afterwards.
So we did intradiscal osteotomy.
Yeah, and unfortunately this patient, not all of them go absolutely perfect, but this patient did have some pneumonia problems with respiratory failure, eventually did require a tracheostomy and had some brachial plexopathy afterwards, but currently in a sniff, does not have an infection, recovering motor, and happy with her new alignment.
Yeah, so she's actually pretty totally straight. So do you want to switch back? Izzy, do you want to give any comment on that? So we basically tied into a previous system. This is a rheumatoid on anti-inflammatories. And what would you have done? Were we overkilling? Did we correct too much? What's your thought?
I think you did what you had to do, what you needed to do. You didn't do any more, didn't do any less. The only thing missing from this is an infection at this point in time. I like the idea of the PEG tube a month before. That's not something that I have routinely done, but I think that's a good idea for these nutritionally depleted individuals. But these are the toughest cases. I don't think there's anything tougher than this in spine surgery.
Sig Bourbon?
Yeah, I think it's a terrific reconstruction. I like your use of the anterior column reconstruction. I think you went with C3 to T1 there. And where do you think you got the incremental, where do you think you got the most out of your correction? Do you think that work that you did at the intradiscal osteotomy at T2-3 really did much for you?
Absolutely, without a question. The little ones in the front were nice. They made the spine malleable. And again, as you probably saw, I don't like to use anterior hardware. I like to keep the spine flexible. I've not had these grafts spit out, fortunately. But we had the subaxial spine malleable, but then when we had this T2-3, I think Rod came in for that, right, Rod? When we had that loose, we could literally lift the head up. We actually had her in a rigid frame, Mayfield. We could literally pick the head up and just dial in a completely new alignment. So that was, for me, the big breakthrough was that upper thoracic osteotomy. Rod, any thoughts?
Yeah, no, I mean, I think the intradiscal osteotomy really got the correction on this one.
What are your thoughts about doing just a 3-column osteotomy instead of intradiscal? Maybe getting a little spinal column shortening.
Clearly, again, just the other day, we actually did I still do PSOs or vertebral body resections, but I have become so enamored with staying in that disc plane because it helps me just stay out of vertebral bleeding. It gives me an alignment reference in this very distorted spine. So for me, that was a simpler thing. And again, the expandable cages in this case actually were a really nice way to disimpact the spine and preserve the length of the neural axis rather than compressing it. So there's no fold in the dural sac. So those are just my thoughts. I use the anterior part as a fulcrum, and I don't feel bad about kind of compressing down onto the cord.
One thought that I'll add to the discussion about positioning these patients. I've become a big fan of the pneumatic Mayfield headrest. So I'd encourage you guys to look at it. It's got two handlebars on it. You can sterilely drape them. You can flex as far forward as you want to do your decompressions, gain your access, put your implants in, and then you can lift everything back up in a controlled fashion to get your correction and do the rods in. So I really like that, and I've used that now almost exclusively.
I would like to have it. Dr. Hart and I both nodded here right now because we've both had conflicts with our administration. I have seen this multiple times. I've played with it in our anatomy lab, but we don't have it in our OR. I totally agree. All right. We'll have to come to close. Rod, do you want to take us out from here?
Yeah, no, I really appreciate everybody's participation. And, I think this is a very challenging area, as Sig and Izzy, and then I don't think we have time. Yeah, sorry, Jared. You really have to think of a lot of things, not only are you dealing with balance, but also and in that case that we showed, there's certain things like myelopathy, quadriparesis, and other factors. And again, I think the cervical thoracic junction it's an area that we're learning more and more about, and having a dropped head on top of that just makes it more complicated. So really appreciate everybody's input, and look forward to seeing everyone at the next conference.
Thank you, everyone.
Great job, guys. Great cases.
Thank you.
Thanks, everyone. Thanks, SNI.
Thank you. Thank you, Jens. Rod, take care.
Great. I want to see
Good job, everyone.
Sounds like we need to put a clinic on for IDOs.
Exactly.
I was going to verify that.
Don't